Thank you, dear Chairman. My name is Panos Antsaklis. I am an assistant professor in obstetrics and gynecology. And I have to say that when I decided doing obstetrics, I thought I would only have to talk about nice things to people and avoid paperwork. But as I grow up, I have to do both of these things. So one of our roles is to talk about the bad things that may happen during pregnancy and do all the paperwork as well. So we're going to talk a little bit about how we should announce this bad news to parents, possible parents. Now, when we talk about a perinatal loss, this is the loss that could happen, the loss of pregnancy that could happen at any stage during this pregnancy and the first few days after delivery. And when we talk about perinatal loss, the question is, when we talk about a loss, is we talk about the loss of a loved one. But in case of a pregnancy, we're not exactly sure what is this loved one. Is it a person? What is it exactly? Is it something that we have planned? So is it a loss of our future goals? Is it a loss of our normality? We may have bought everything that we need for this baby that is going to be born soon. Loss of our dreams with our partner for the future. And of course, there's a completely change of the quality of our life. Now, when we talk about perinatal loss, there are two Greek words. They're different in English, which have to do with grief and suffer. And these are very similar together. They have a very similar origin. And the origin of these two words from ancient Greek show the complexity of this situation of grief. Perinatal grief involves two people mainly, the father or the two partners of this pregnancy. And as life changes, when we talk about perinatal loss, we don't only talk about the loss or the so-called intrauterine death, but it could be a first trimester loss. It could be also a selective reduction when we have a triplet pregnancy or a quadruple pregnancy and we have to do a reduction to a twin pregnancy. And this is a very serious decision that a mother or a couple may have to take, because most of these pregnancies are pregnancies that have derived after IVF pregnancy. So maybe they have gone already through a lot of emotional ups and downs. So they have to decide once they're pregnant that they have to do a reduction and put their pregnancy in a risk for as a whole. And of course, there is now a change in the Greek law as well, the last few years, that allows us to proceed to termination of pregnancy at any stage of the pregnancy, even at 40 weeks, if there is a serious reason from the fetal point of view. And that, for example, in our department, in the first department of obstetrics and gynecology in the University of Athens, the last 2 years, we had about 38 terminations in the third trimester, which is something new. Before 2 years, we had 0. So you can see that we have to deal with something new. And what is unique for perinatal loss is that it is a loss that is, as we say in Greek, is not memorized. So I don't know if I have translated that very well. And what does that mean? It means that when my uncle died, we were very sad, and we sat down with my cousins and we discussed about my uncle and how what a great guy he was, how we had a very good time with him, how we spend summer and Easter vacations with him. So at the end, we were sad, but we left with a good feeling because we talked about him and how good was the time that we spent with him. Now, this is something that we don't have a chance to do when there is a perinatal loss. There's nothing to discuss about that. And there are 9 points of development of this prenatal psychological bond. So as doctors, what we usually come across is a couple that will come and say, we think we're ready to start trying for a pregnancy, or from the next month or in 3 months. So there's an enthusiasm about what's going to happen. And of course, when they are pregnant, of course, there's again enthusiasm. We're pregnant, and then the first heartbeat, and then as this pregnancy goes on, the feeling of the fetal movements, and of course, after delivery, the first days. And this is a step-by-step developing of a very strong prenatal and postnatal psychological bond. But what is the reality? The reality is, of course, when someone plans for a pregnancy or they find out that they're pregnant, they think that everything will be great. There are not going to be any problems. But in general, there is a 15 to 20% of first trimester pregnancy loss. And this percentage, which is the most common pregnancy loss for obstetricians, goes up as the age of the mother goes up. And of course, it can be up to 75% for women who are 45 years old or older. And this is something that we see more and more now with the new IVF procedures. And again, regarding perinatal loss, there is something else that is unique, and it's a Greek word which is called prodromikopenthos, which means that you grieve for something that you don't already have. And the other problem is that it is a so-called silent loss. So when, as I mentioned before, you had a loss of someone that you love, like your uncle or someone like that, you have the opportunity to discuss about that. You have the opportunity to go to an open funeral. You have the opportunity to sit down after the funeral, have dinner like we do in Greece. I don't know what happens in other countries. So you have the time to discuss about it and then feel much better. And this is something that doesn't usually happen with perinatal loss. What happens when we announce for the first time the bad news to the couple? Of course, the first reaction is they're under shock, so no one is expecting that. And the first reaction is denial. So they will say, no, this is not possible. It's not happening. Please check again. Then there is anger. And of course, sometimes, why did this happen? There may be a fight between the couple. Was it because I was smoking, because I was lifting weights? Many, many questions. And of course, what happens after that is sadness, possible depression and post-traumatic shock, and even feeling guilty that something is our responsibility. So denial, anger, negotiation, can you check again? Maybe you didn't see very well, depression, and then it comes acceptance. And this is our role to help for the final step, which is acceptance. Now, no one, especially from the medical staff, wants to be involved in breaking bad news, but it is our job to do it. And it is a key stage how to do it in dealing with these situations. In order to give the opportunity to the couple to accept all that, you have to give them time, and you have to do it in the best possible way. So announcing the bad news and trying to deal with all these reactions that we mentioned: denial, anger, feeling sad. In order to do that, you have to develop what we call a therapeutic relationship with the patient. So when we examine a woman as obstetricians or gynecologists, there are some conditions that we should take under consideration. It could be a first trimester pregnancy loss, so maybe we're doing a transvaginal scan. So we need to give time to the woman to be in a more comfortable situation, be more decent. Maybe her partner is not with her at the time. In some hospitals in Greece, women are not allowed to have their partner when they're doing a transvaginal scan. So you need to give her time to have her partner with her if she wants to, of course, if she wants to. And then you have to be very clear with your communication. You shouldn't be announcing this bad news when a woman is sitting in the gynecological position, she's not dressed, and you're standing over her and just saying the bad news. So you have to give her time to be face to face with you, sit down, and then if she wants to have her partner with her, and then know how to start the bad news. Unfortunately, there's no in-between way of how to announce the bad news, so you have to be very direct. I'm sorry I have to say that, but the fetal heart your baby's heart has stopped, or I'm afraid I have some very bad news. And then you carry on continuing with what you have to say. So very important, ask her if she wants to be with someone else. Maybe she has come alone to the hospital, or her partner is outside, as we mentioned. And then very, very important is ask her how would she like to be asked to refer to her child. This is something that we're not used to in Greece. So in Greece, we don't give, or it's very rare to give names before delivery, but in other countries, this is very common. But as we mentioned, life is changing. We have people from other countries now in Greece as well. So we have to adapt to the new conditions. So if the couple have given a name to their baby, we have to refer to them with a name. And another very important thing is how we explain the situation to this couple. It's very easy to use sophisticated language, medical language, and explain to them that it could be a possibility of a chromosomal abnormality. It could be a microdeletion, and you have to proceed to do a whole exome sequencing analysis of your amniotic fluid, blah, blah, blah. But probably they will not understand anything. So you have to be very plain and understandable with the words that you're using. And sometimes we may even have to draw or show them the pictures of the ultrasound. And I remember a case that we had in Alexandra Hospital, which is our university hospital, where we had in Alexandra Hospital, we have many, we call them gypsies, and one of the pregnant women had a fetus with acrania. So part of the skull is absent, the brain is outside, and this is a very severe condition. So we offered them termination of pregnancy about 25 weeks. So it was in the second trimester of pregnancy. And after explaining to them and what we had thought that we had explained very clearly, the question of the father was, but will he, because it was a boy, be able to sell potatoes after it's born? And of course, then we understood that he had understood nothing as well. So what we did is we showed a picture of the fetus, and they decided that they had to do the termination. What we should avoid, phrases like, I know how you feel, should be avoided. No, we don't know how they feel because we're not in their position. We do know that they are feeling very bad because we have been with similar situations in the past, but we're not in their position. And we should understand that there is this fight or flight phenomenon, which, what does that mean? That they may just want to leave the place. It's not personal. They don't have anything with us. It's just how some people react to this bad news. Now, very, very important when you have to deal with perinatal loss is to plan the future. So how you schedule the next visits. Give them some time. Maybe they want to go home and come back in a couple of days or in a week time. It's usually not a problem. And then discuss everything again. And give them as much information as you can on what options are available for how you manage this case and in the future. So the day after is very, very important. Give them the options, present them with the option, and what is the role of the doctor to see as a unique person what's going on. Religious differences, don't forget there are people who don't think the same way as we do. They have a completely different social background, religious background, and cultural background. So what we believe is right, it's not right for them. And then try to give them as much time as you can. Very important is don't let them feel guilty of what have happened, and especially for couples from different religious backgrounds or social and cultural backgrounds, don't let, if there is a husband, give all the blame to the woman, because this is something that we have seen. Now, something that is different for us, for our culture, is something that I had seen in the United Kingdom about 20 years ago. There was an IUD, an intrauterine death. This woman gave birth to her baby, and then she had 2 days to stay in the hospital with her dead baby next to her, which is something that at that point, from the cultural background that I had, from Greece, it was very different. I couldn't understand it. But for her, it was very, very important. When she came back for her next pregnancy, she was something that she was thanking us about, not me personally, but the hospital, that she had this time to spend with this baby that didn't make it, and then that gave her more power for her next pregnancy. Also, another very important example that I was taught back in the UK was when we had a very difficult delivery. It was a home birth that came to the hospital. We realized that it was a very difficult situation once the CTG was placed on the pregnant woman's abdomen. She gave birth immediately. We assisted her to give birth immediately because she was fully dilated. And then the neonatologist arrived. What he did is he introduced himself and he said, what's your name? The couple was, let's say, Sarah and Tom. And he said, well, Sarah and Tom, I'm Dr. Lawrence. What's your baby's name? They said, my baby's name is Tom. Okay, Tom is a very difficult situation. We're going to do the best we can. So they were trying to resuscitate the neonate. They were trying to resuscitate Tom. After 2 minutes, Dr. Lawrence said again, Sarah and to her husband, still, we're in a very difficult situation. We're doing as much as we can, and then keep following them up of what happened. Unfortunately, Tom didn't make it, but this continuous information helped the couple very much. And of course, if you have a loss, you have to be very careful that the information you give for a future checkup, what needs to be done, what exams need to be done. And a very important examination is to give what we call pathological examination of the neonate or of the fetus, which is something that is very difficult in Greece because we don't have adequacy to do for everyone. And of course, it's something that most couples in Greece don't want to do because they just want to get over with the procedure, but it may give us very important information for future pregnancies. And if we have, for example, a chromosomal abnormality or an unexplained neonatal death, we have to give them the information what they need to do, maybe karyotype for themselves and their partners, a checkup for thrombophilia, or for other medical conditions. And we should also inform them that in most of the cases, we don't have a clear diagnosis, but we still need to inform them that in the next pregnancy is possible, everything will be okay. And they are going to be very stressed in the future pregnancy. They will need our support. They will need a very close-up monitoring. And this is where we should focus, planning on the future pregnancies once we have done this, they have overcome this loss and they will try for a next pregnancy. Of course, we shouldn't focus just on the new pregnancy, because if they don't have answers, there's not going to be something that will make them feel better. It will be something that will stress them even more. And during the next pregnancy, there will be some cases that will make them feel very stressed, very uncomfortable. For example, I remember a case where a severe cardiac abnormality was diagnosed about the second trimester. This couple decided to proceed to a termination of pregnancy. In the next pregnancy, we informed them that they would have to have a detailed scan of the fetal heart. What they said is, we're really sorry, but we don't want to go to the same pedocardiologist. And when we said that, why is that? Were you unhappy? No, we were very happy with him, but we cannot go in the same place with the same person and announce to us the bad news. So this is something that we should keep in mind. And finally, what we say for the doctors is that there's no expert in breaking the bad news, in announcing the bad news, but you can become better or doing less and less mistakes the more you do it and the more you deal with it. So we shouldn't forget that apart from the couple, there's also the medical staff, and the medical staff, it is something, these conditions, announcing the bad news is something that can be stressful. It may make you feel that you're inadequate. You may not feel ready to do that you don't have the knowledge to do it. And of course, when you go home and you take with you everything that you have dealt with in the hospital, you can feel stressed as well. You can have anxiety as well. And this is something that it can make your job more difficult and less adequate, because again, you may be in denial. You may decide to hide some information or mislead the patient, not because you want to, but because you're not ready to do that. And this is why the last 2 years with Professor Antsaklis, who's the director of our department, we have started doing these courses for breaking bad news and for communication, which, as I said at the beginning of our presentation, it does take us out from what we call the everyday clinical practice, but it is very, very important. Thank you very much for your attention.